So this week we're actually up to chapter 5 in our book, and what we've normally been doing is I've been doing my own little narratives here. So thank you.
Yeah.
This is a nice change.
Yeah.
Well, and the reason why I asked you is because you're one of the authors.
Yeah, it's kind of fun. I was lucky enough to get invited to write the chapter, and I think a bit of background stuff kind of influenced that.
Yeah.
Being really involved in this area.
Yes. Especially because you were doing the not scope of practice, but advanced practice.
Yeah, and I guess I was involved in both. So I was involved in writing that scope of practice document.
Yeah.
That's been published through OTA, and also the on the competency standards advisory group as well.
Yeah, which is great.
Yeah, but my passion is advanced practice as well.
That's fantastic. It's pretty interesting, I think, when you actually think how far we've come as a profession in such a short time.
Yeah.
So this actually follows pretty soon after we've done the history lecture, where you featured again. And I think we've come a long way. I'm just going to press forward on these slides for a bit. So there it is, the pre-reading with your name and Anne's name. And so the two key things that I want the students to get out of today's session is that they just have a really broad understanding of the scope of OT practice in Australia.
Yep. And
you and I might mention some areas of difference in the world that we know of from our own experience. So it's going to touch on things like what we do, what we don't do, and even a bit of a conversation around some of those things, because it's not necessarily black and white.
Yeah. And I think even different OTs have different opinions about what we do and what we should do and what we don't do.
Yeah.
And sometimes the association even surveyed OTs about whether they think we do want to push into areas like medications. People said no for medication, but those sort of things. It's a conversation that needs to be had.
Nice. And the other thing is that what comes with that is responsibilities and the need to always continually develop your practice.
Yeah.
And the legal requirements about what you can and can't do based on your level of education and your base education, etc.
Yeah, and what you learn after that as well, and not doing things which you aren't competent or safe to do things. And when you graduate, you've got the very basics, and nobody expects you to be an expert in everything.
Yeah.
Such a long journey as an OT.
Isn't it? Now I'm going to get you to press that forward button. Yeah. Okay, so we're going to use the slides that you prepared for the book, and if you carry it to the next one, we're looking basically, the definition of scope of practice. Basically is describing what OTs do.
Yes, and that's probably what, when people are coming into an OT program, that you've got some idea, and often you've had an experience or something before, but most people don't realise the breadth of what we do. And when you talk to your partners, when you talk to your friends, when you talk to other health professionals, often they have a really limited understanding of what we do. So I think it's it's a pretty important thing you'll never get it totally sorted because it does change. Yeah. But you need to have some sense of what we do so you know what you're getting into. Yeah.
That's also the reason why I interviewed a couple of graduates, was just to hear about a day in the life of their job.
Yeah.
Because it's sort of really different. They all come at their work through an occupational lens, and they're there to enable people to do the things they need and want to do in their lives. But how they do that and the people they work with does change.
Yeah. And that some days you can have days where or in some jobs you can be spending heaps of time face to face with people, and in other jobs you might see a person and then not see somebody face to face, but have so much other stuff that you're doing behind that for hours or days.
Advocating and blah blah blah. Okay, so it says here the things that we do, but also the scope of practice can change as the profession and needs of society evolve.
Yes.
Yeah. So it's not been the same throughout, the history of OT in Australia has shown that, hasn't it?
Yeah.
We were talking about the origins.
Yep.
It's
and
so
wartime
different.
OT versus refugees and asylum seekers were really, it was an important issue over the past decade, and I'm sure there's like there's OTs getting into the impact of technology on children and writing about that in the newspapers. So,
wonderful.
yeah.
Isn't that great? And that's what I love about the profession. It just evolves all the time with society.
Yeah.
Yeah. Okay, so factors influencing scope of practice. Do you want to talk a bit about this? I know this is pretty much your favourite area.
Yeah. So the competency standards are kind of written by the profession for the profession.
Yeah.
They are quite broad statements. So it's, for example, things like we need to be culturally competent. We need to know about how to work with people who are of Aboriginal and Torres Strait Islander origin.
Yep.
We need to have digital literacy. That's a new one.
I love that
in
one.
the latest competencies. You're a little bit biased, but really important that we know how to use things like email and communicate with other people and use technologies in our practice too.
Like telehealth. And,
Yep.
Yeah.
Yeah, and it also kind of extends to, they have one about assistive technology as well. But they are quite broad statements, so it does give OTs a lot of flexibility
that's good.
in how they work and what they do. But the underpinning things are like how to communicate with people, treat people with respect, you facilitate occupation, that sort of stuff.
Yeah.
So
the competencies themselves were, that was obviously a combination of the OT board and OT Australia.
So
yes, who were the people who wrote it?
Yeah, so
the new ones.
Yeah, that's different. So the old ones were definitely written by OT Australia, which was the association, but the new ones were commissioned by the board. So the board said, let's get a company who are OTs that a lot of us know to write these for us. And then they put together advisory committees. So they called out to OTs around the country to be on different committees to kind of help with the shaping of those competencies, because we all bring really different perspectives. None of us know all the stuff that OTs do and all the key stuff. So it was really a group effort at the end of the day. Yeah,
and as you know, I use them in my teaching directly all the time, especially with fourth years. But I'll add the PDF of those to to this resource, so the students in first year can have a look at them straight away. I wanted to ask you a little bit about the difference between, say, the OT board and Occupational Therapy Australia. So we're not really going to get into this in this course, but could you just briefly talk about the difference?
Yeah, so the OT Australia is the professional association, so you can choose to become a member, and that's really about supporting OTs everywhere and kind of promoting OT and what we do, running learning opportunities, those sort of things. But it's by OTs for OTs.
Right.
The registration board isn't about helping OTs, it's all about protecting the public. So you have to pay them to work, to be registered, and their whole job is to make sure that we're competent, that we act with integrity, that we don't hurt people as health professionals. And that's important for us because it protects our name as OTs. But a really different
so
point
protect
of view.
The public
and
promote the profession.
Absolutely.
Okay.
And the board, the registration board, has OTs on it as well as non-OTs, like lawyers and lay people. It's a small board, but it's mixed.
And the board's inside APRA, right?
Yeah. It's supported by all the APRA and
it must be so confusing for first year students. I mean, probably even second or third and fourth year students. It's like, what goes where? And this is not the only time we're going to talk about it, though, in your degree.
But if you do hear OTA, OTB, OTC, APRA, APA, all these acronyms, you just flag, what was that one again?
Yeah. Awesome. Actually, just the federal and state laws. Just briefly talk about. I'm going to still click forward, but just talk a little bit how that changes.
Yes, and
where you work, kind of laws. I'm going to flick back so it seems it's congruent.
So they don't change all that often, but when they change, they make a really big impact. So, like a couple of years ago, the Mental Health Act changed. And that. All the people who were working in that area, like OTs and social workers, psychologists, had to learn the new act and what it meant for what they did with people. Especially around that space of, can we force people to go into hospital when they're not safe to be to themselves or to other people to live at home? But these rules change, and it changes what we can do, what we have the power to do, and what we can't do. there's, even in my lifetime, there's been lots of changes to laws around child protection, around deinstitutionalisation probably happened a little bit before my time, but it was still happening. Like, it's a slow process for these. And the work in the workspace, laws have changed within the past decade, definitely.
And we've got to think about state laws and also federal laws.
Yes,
So, and it depends who we work for to which ones are in play. They're all in play, but it depends also on the context. So,
and some will matter more than others where you work.
Yeah, thanks for that. I think that's something, you know, that when you're in prac, you also learn a lot more about that.
Yeah.
Because it's right in front of you, and they're good questions to ask when you're out in prac, is, you know, which laws.
And sometimes your practice educator will make you read them when you get there.
Ah, okay.
Yeah.
And so students,
or sometimes
like,
a summary.
Yeah. All right, so this is factors influencing scope of practice, and I was actually just looking back over the book. This is just early in the chapter, just on page 63. So talk about those individual factors first.
Yeah, so the training you receive at university, every university is a little bit different. I actually get questions from prospective students or current students sometimes of which is like the best university or the right university to be in, and I'm always like, every university, you'll meet the competency standards by the time you finish. And it doesn't stop you working in any area, but they do have a bit of a flavour. And I'm not going to tell everybody here what every uni's flavour is, but it's slightly different, and people will have strengths. I have stuff that I'm really good at, so I'll sneak that into my teaching. So the students from here will know more about those things, and maybe a bit more of an intro to some other things.
And that's what's great about having such a diverse team. And I think that's a real strength. I'm just going to blow our trumpet right now. But we have such a diverse group of people teaching into this program that the students do get a lot of exposure to different things, which is
There's not many places that you won't feel confident to at least step into.
I agree.
When you come through this uni.
Okay, but and then when you leave uni, you know, I was speaking with Amy as one of the graduates, and she's actually just about to start a postgrad cert in rehab. Through JCU.
Great.
And you know, that continuing education, it can be formal, informal, it can be, you know, like other qualifications, it can be short courses. What sort of things have you done?
I have done some formal things, like doing my PhD and doing a grad cert in research commercialisation, which actually...
I didn't even know that.
So it was basically a business degree that linked to how we put research into practice, but that was so helpful for me moving into private practice, because as a private practitioner, the business side of things really matters.
It does.
You've got to make sure you get paid and you've got a good setup and everything. So there's that sort of thing. I've done some really big courses too, like I did lymphedema management training, and that is like at least 3 weeks full time of just learning about one thing. And I actually didn't put in my last assignment, but I got everything that I needed out of it anyway. And more. So that was a fantastic experience. But a lot of it you build kind of on the job, my own study, learning from other people, catching up with people, and trading stories and questions, and
asking more senior experienced people, other professionals.
I've learnt a lot from other professionals, and sometimes there's some great, for example, physios or psychologists that I've worked with who were actually kind of really good occupation focused people. And then sometimes I've actually taught, say, physios some stuff about, like, often they've asked me to come in and teach them things about functional anatomy and just kind of refresh them a little bit, especially if they haven't been in that field for a while. So
especially upper limb?
Upper limb, usually, shoulders, and there's always a few insights there.
It's that funny delineation that happened once, and it seems to have got stuck a bit. But I've noticed physiotherapists are becoming much more function focused and to be honest, occupation focused.
Definitely, and I think once they do it and see the benefits of it, which we've always known as OTs, sometimes it takes a while for us to get that perspective. But
I think it's wonderful that we're all like singing from the same song sheet, well, in harmony. On the same song
and
sheet.
I think some things like the NDIS force us to do it, because like it is around people's goals and they're everyday, so other professions have to a little bit fall in line with that.
So true. going to keep moving forwards, otherwise we'll talk all night.
Yeah.
So who do we work with? And this is going to come up in the other thing that we're going to talk about, but wow, right across the lifespan, from birth to death, no matter what age you die.
Yeah.
Older adults, people working age.
I've never worked with a neonate. Like, it is a thing that OTs do, like people who have kids who have just been born.
Yeah.
I haven't personally worked there. Have you worked with
One
babies?
of my friends in Victoria did,
Yeah.
and it was just, for her, it was just so precious.
Yep.
Yeah.
Yeah.
And splinting these tiny little hands. Yeah.
Yes. Yeah. I remember because I taught this foam cutting workshop about how to make things out of foam, and one of the examples, which was from a study, was for premature babies, you carve out these tiny little things for them to lie in to put them in the right position.
It's like a nest.
A little foam nest for them to lie in, which was really cute to teach people that, even though I don't do that normally. But I like that. I tend to see kids who are 13 plus adults and older people, and I love that upper end when people are dying as well. It's really awesome.
Isn't it a privilege?
It is such a privilege, and it's such a real moment because people are often quite honest about their life and their needs, and you can do little changes which just make those last few weeks so much more quality and bearable.
I read this thing once, and it talked about palliative care being a health promotion area.
Yes.
I love that phrase, that you're promoting health in this time, and it's physical, mental, social. It involves family and friends, and it's such a privilege.
And even when people pass away, you know their story as an occupational therapist. And that moment where you go and say pick up equipment from the house, and you sit with the person, the people who are like really grieving. But it's great where you can just sit down and go, how was the funeral? What was it like for you? I remember when the client said this. And,
they were planning it. I actually think that would be an area I would love to work in, is palliative care. And especially because I have so much personal experience of it too, that I understand it from that side, and I really respect the death process. But I also, because I'm a minister's daughter, I've been around death a lot. So, But
I think that's where like who you are also kind of shapes what you feel confident with, because I know I remember interviewing people about practitioners about what they do in palliative care for an education thing. And some of the younger ones who hadn't experienced like deaths in family or deaths themselves tended a little bit to shy away from it. And I remember like my first couple of people that passed away on me, it was pretty heartbreaking.
It is.
But that's an important part of finding out how you feel about death. And,
because we've got it. Isn't that great that though you saw that in yourself, you recognised it, so you then knew you had to do something with that.
A lot of talking, a lot of processing and thinking, and
no suppressing.
No suppressing.
But wondering perhaps why you're a bit snappy at home, and then thinking, oh, I'm actually grieving. Like, oh gosh, I'm grieving too. And we have to keep that professional face there with the family, but we do let a little bit of ourselves there, and sometimes we cry, and that happens. And when I worked in mental health, I had some really special people die, that had killed themselves suddenly, or it had been a slow death. For example, I remember one woman who had taken a whole packet of Panadol and took 6 months to die. So living with her and her husband and working through that with them, and just knowing, that was my very first job. She was one of my very first clients, and I'll never forget her. But knowing full well that she was going to die, and that I found the saddest thing was that, I said, I was thinking about you on the weekend, and she said, oh really?
They don't realise how much it sits with you sometimes. And I guess in terms of like scope of practice, there's that idea that some of these things you'll fall into when you get out there, and hopefully you've got a really good bunch of people around you to support you. Sometimes people make really choices though to either go into different areas of practice that they're ready for, or to sometimes even within a team there might be somebody that it's just way too close for you, so you might just split those clients a little bit.
I actually had one where we just for the client's sake, the social worker on our team took the counselling aspect. She was really good at it.
Yeah.
And I took the return to work component, and we literally, and we had a conversation with the client and said, look, these are our skill sets.
Yes.
And she said, I would actually prefer that because I don't want to bare my soul to everybody.
Yeah.
And I'm really happy to separate that off with the social worker and have time with Gail to talk.
Yeah.
And then Anita, you just get to action to get me work.
Yes.
And that's how it turned out.
Yeah.
So it was nice. And I was, you know, you're at different times of your life where you're good at things and not so good at other things. So yeah, we should keep moving.
Yeah.
So yeah, where do we work? Well, I think we've alluded to a lot of that through the things that we've just been saying, and also through the interviews we've done with the students.
Absolutely. I don't think this is not like the only list though.
Hello.
Because when I'm looking at that, like next week I'm going to court. Not in a bad way. In a good way. But I did, there was a person, I used to work in the prison setting, and then there was a person that needed to, was going to be leaving jail soon.
Yep.
And they needed me to go in and do an assessment of how they cope when they leave jail.
Wow, that's great.
And then now I did that to provide information for the prisons, and now they liked that report that the judge wanted me to come in next week, so that I can answer any questions they've got in the courtroom.
Excellent.
So it's a bit weird to go from like driving around rural countrysides, visiting people's homes. I'm actually popping into hospital that morning before I go to court, and then I'll go into court.
What are you going to wear for each of those things? Because you're going to have to dress for each of those kind of personas.
I'll take my jacket off when I go to the hospital, take my tie off, and then when I'm about to walk into court, everything goes back on. Yeah. But then when I'm out of the countryside, I've got steel cap boots.
Absolutely.
And I've got a polo shirt. And,
I've ever told you the story when I did a return to work out at a wood mill in the Otways, and I had to wear jeans, Blundstone boots, a really heavy jumper because it was so freezing cold. Yeah. And then my next return to work in the afternoon was at Broome prison. So I had to change into a suit. Yeah. And then head out to the prison to do a return to work for a prison guard. Yep. And those sorts of days really bring it home to you how amazingly diverse the role is, the profession is. And that was all just in OC rehab, but very different.
And even the way you talk when you walk into each of those environments is so different.
Yes. So this list is really short, but I suppose it's trying to capture the door into a range of places.
A lot of people will work in these places. Yeah. Continuing, and also when you graduate.
Yeah, and I think probably National Disability Insurance Scheme has opened up the bottom one there, the private practice area, in a huge way for OT. Whereas I think, when I was going through, only physios really looked into private practice. Yes. But I went through it a little while ago, and things have been evolving since. But the NDIS has just changed it overnight. Yeah. So.
And we passed the tipping point a few years ago. Yeah. In terms of like public versus NGOs and private. Oh, yeah. That happened about 4 or 5 years ago, and then but even now there's that huge explosion in private practices. Yeah. And I go to events and talk to people I've known for ages, and they're going, yeah, I'm setting it up right now, I'm about to finish up my job with wherever to start my private practice. Yeah. Or they're in it, private practice already.
It's amazing. It's just astounding how much things are changing. Yeah. So what do we do? It doesn't matter where we work. This is probably a really nice slide, Kieran. Nice job.
Yeah, it pulls it all together.
Yeah. Do you want to talk to this?
And so I guess it doesn't matter who we're working with. It's the same sort of steps. So you find out what's meaningful to the clients within the context of where you work. If you're in work rehab, you're going to have to focus on work.
You are.
And if you're in the community and working for, say, the NDIS, you're going to have a scope that you work in as well, what they will pay for. Yeah. It doesn't mean that you can't occasionally have a conversation about a couple of other things that are relevant and to give a little bit of advice, but most of your work will be what you're getting paid for. Yeah. But it still has to be meaningful to the client. Yeah. I like that. Yeah. And then you figure out what's working well, what's not, and then we do something about it.
Yeah. And the doing something about it, just so first years can feel a little bit of release here, that's what third year really focuses on in this degree. So first year is all about, getting a grounding and a basic health science degree, and then second year we move more into, well, how do we assess and work out, and also our therapeutic skills and making sure we're safe. And then moving into third year saying, okay, well, how do we actually provide services? How do we provide, some people call them interventions. And then in fourth year, you're really finessing that.
Yes.
And a lot of it's practice. And it's also about getting ready to practice. So being the consummate professional. So
and I guess even when you get past that though, like I think when you graduate, you're prepared for kind of the simpler things, not simple, but definitely like the slightly less complex ones. Or if you're gonna be working with complex people, you'll be pulling on more support at that point in time. So I think you still don't know all the interventions even when you graduate. Even now, like I'm hoping to sign up for some CBTE training. I don't even know what that is. I know CBT, but I don't really know what CBT is. So I'm going to add the E in the end.
Can't wait to hear.
Yeah.
Oh, that's awesome. All right, so some examples here. I mean, the students can actually read these. Any of them jump out at you that are exciting? Some are very basic, aren't they?
It's fairly straightforward. I think there's some things we do a lot. So, like a lot of OTs feel really comfortable in, say, the recommending equipment and devices space. Like I think that's historically been a big thing. Sometimes that second one there of working with parents and caregivers, we've always done that. And some jobs it's actually, that is your whole job. But I think sometimes there's a push now over the last couple of decades to really making it working with a whole group of people. And actually at the moment I'm going to meet this client at some point in time, but he's in hospital way away, and his parents are close to me. So it's the parents that I'm working with right now, preparing for that return home.
Fantastic. Yeah, that's great. And then there's some areas which are like power drive wheelchairs. I wouldn't even go there. I don't know the first thing. I would not do that. I would go and get extra training if that was suddenly my job.
And the reason I do a lot of those lately, but that's because that is something I know a lot about, and complex home modifications. So I actually work in one of the areas that I work in. All those clients that have those complex things, I'm like, yes, I'll do that, but I don't have time to see everybody, so I want the other OTs in the region to be doing some of the other stuff that I'm not so good at.
Yeah, isn't that great? Advocacy is another big role.
Yes.
Yeah. Okay, so this is a really interesting one.
It's the should I do it? Should I do it or shouldn't I do it? The first one is kind of like, is it clearly linked to occupation? And sometimes we'll do little things along the way to kind of prepare people. So for example, we might use some psychological techniques, or we might use some hands-on techniques. But at the end of the day, if we're not thinking about what people do, then that's not our core business. Although sometimes if you're an OT, it might prepare you to do things where you're not actually doing occupational therapy, but you're doing another job, but you're bringing those skills into it. But if you're doing occupational therapy, it has to be linked to occupation.
Are you alluding to sort of like those case management roles, or?
Things like case management roles. Sometimes people go into sort of HR roles even, or being a team leader, where they lead others, but their ability as an OT to talk to people is really key to that.
I find that in education.
Yes.
I think that's why OTs who come into education generally
pretty passionate about it.
Because I think so much of our role as occupational therapists is educational role. So it translates really nicely here. And leadership and teamwork and all those soft skills. Yeah, nice.
And I think like even sometimes in some of my work rehabby stuff, I will use things like first aid when somebody has an injury. But then I'm also involved in their return to work after that. But I'm one of the people on site that's trained in first aid, so...
because you actually talk in the chapter about a few things. I think we're going to get to one of the slides, but it's some of the things you don't do.
Yeah.
But, well, here we go. We probably, let's talk about advanced scope of practice and extended scope of practice.
And the nice thing about this is stuff that you don't have to do or won't be doing when you first graduate because you're not there yet.
Yeah.
So to kind of take the pressure off a little bit, there is stuff that, like the medico-legal thing I was talking about, going to court, when you first walk out the door, most people won't be going to court, fingers crossed. Because it's like an uncomfortable environment, and I'm getting called in as an expert witness, knowing a lot about a certain area, which is prisons and cognition, so how people think. So that's an advanced practice. There's things like driving, where you actually, it's recommended, it's not law, but it's strongly recommended by a whole lot of different systems that you go off and do special training in how to assess people with disabilities to drive.
And I would say that families should be asking for that, you know, an experienced therapist with additional training doing that.
Yes, yeah.
And I think there's a recommendation that you don't do, say, driving assessment until 2 years out.
Yeah, you just have to know enough about conditions and working in general and how to communicate with people, because it's especially that moment where you have to tell people that they didn't do that well in the driving test and that you'll be recommending to the GP to not have their license renewed. Yeah. That's a really hard conversation and not something you can do in your first day out. No. And I think there's probably lots of other areas as well that are very similar, like when we were talking about palliative care before and those sorts of areas. It is that experience. And what I love about OT is the structure, and that you can walk out into a new grad position and get support on the job, and that if you don't have support on the job, perhaps, you know, think about getting a supervisor or a mentor outside. We should probably mention Mentor Link at this point. Yes, it's a pretty good space. And I think even like special interest groups where you're surrounded by a group of people in that area, and then you can figure out who you click with and who inspires you as well.
So what about extended scope of practice? Yeah,
so that's not a huge thing at the moment for OTs in Australia. Extended is where you do stuff that usually other professions would do, and usually we would definitely not do. So usually they have to change the laws. Like for example, with podiatrists, they can now prescribe things like antibiotics and all that sort of stuff. Only very certain podiatrists who have done special training. But they actually had to change the law to allow them to do that.
Is that like for foot infections and things like that?
So it's still related to feet, which is what podiatrists do. But they needed that extra knowledge about medications and safety, and it's really rigorous.
There's big contraindications, there's risks,
And there's physios who already order x-rays and interpret them as well. So that's extended scope, but it's so useful because they're usually the person that's going to be doing some of this therapy anyway and directly needing it. So it's a bit of a waste of time for them to go to a medical officer just to get sent to an x-ray to come back to the physio anyway. So it really improves the patient experience if the physio can do that. So it has to make sense more for the patient, plus that health professional needs to have a way to get those way more advanced skills.
When I was working in Canada, OTs were permitted to do extended scope of practice in acupuncture.
Great,
So, and add it to their role. So I noticed in the book it was mentioned. And that you know, here in Australia it would be that if you do that and you're qualified, you're doing that as a different professional. You're not an occupational therapist when you're doing that.
What's fascinating though that I found out the other day is I met a dry needling trainer. So same needles, but just a different way of thinking behind it. Acupuncture is based on an Eastern medicine, Chinese medicine, whereas dry needling is very much Western medicine theory, and poking needles in different spots. And they've actually trained a whole lot of OTs around Australia, which I didn't realise, who were using it in practice to promote occupation.
Okay, that's really interesting. So it's a new modality.
But those OTs got training, obviously, to do that. Because I wouldn't feel confident stabbing needles in anybody,
No.
and I don't really want to. So at this point in time,
Yeah, you do want to feel like it's something that you feel comfortable doing to somebody.
Yeah, and that I think will enhance my practice.
Yeah.
And
I'm just going to just keep scooting forward because people are probably like, come on. But we're actually getting to the what do we don't do. But how do we broaden? We talked about taking extra courses and training, reading literature, attending workshops.
I think the other one that is probably in that first one, but I didn't really lay out, was clients. Clients have taught me a whole lot, probably more than anything else. So I always ask clients what's been working, what hasn't, what did you think about this?
I'm glad you said that.
Yeah.
It's so true, because the thing is they are the expert on their life and their body and their mind, and they're asking for help, but you don't want to be going over and saying, have you tried X? And they turn around and go, yes.
Always start with what have you tried?
What have you tried so far? What seems to work? What problems have you had with the things you've tried? You know, where did they go wrong? What else? You know, and then take it from there.
And people invent even devices that nobody else has made before. But then you can go to another client with a similar issue and you're like, saw somebody who suggested, what do you think about that? And that's a really nice way of spreading that knowledge, but doing it with a little bit of a filter for us too.
I like it. I think we should, So what do we not do?
Okay, this is somewhat clear. So we don't cut people.
Nope.
We don't put stuff inside people. In saying that, some hand therapists do debriding, where they shave away wound tissue, just to clean the wound. But we're not cutting things out.
No.
We don't do medications. That's not a thing. And that's probably a nice thing because it's such a big area. Let's leave that to medical officers and nurses.
Pharmacists, nurses. Medical
There's enough
officers.
people doing it.
They're good at it too.
And the other one is, anything that's kind of like a key for somebody else in their profession, like really central, that's pretty focused and that's spent years studying to be able to do that, we're probably not going to do. Like the x-rays or prosthetics.
And, you know, if our students want to be doing prosthetics, they can do that degree at USC straight after they finish OT.
They can.
We strongly recommend it for those who want to do prosthetics.
And what's interesting, there's like, they'll do really, people who are, say, a prosthetist or orthotist might do really fancy orthotics, but even the simple splints that we make, they're orthotics. But as OTs, it's only to a certain level. We know where our boundary is. We learn where our boundary is.
And a lot of people do go on and do further training in those areas if they specialise in that area and they have that extended scope, or they're specialised. So we advance scope, advanced practice. Yes. So we're, you know, we have some of our graduates who've gone off and done those kinds of jobs, and you know, same with the last place I worked, and you know, they love it because they just really like this one area, and they love seeing how by helping people fix their hands, they get back to doing so much. And it is occupation based. So it's occupation focused.
It's occupation focused.
It's not occupation based because it's often very biomechanical.
And there's a fascinating recent study in that area where they talk to these advanced practice hand therapists who were doing a lot of really like medically type things and doing splints and hand therapy and stuff, but they still had those little glimmers of occupation coming through. And this was a study done by somebody who is really right into we should be doing occupation all the time. And they still found this happening, which is great.
That's wonderful. Is that an Australian study or a Canadian?
That's an Australian study.
Good.
Local Queensland study.
Fantastic. Basically, the legal requirements, we have mentioned this in other chapters as well, but we have to work within scope of practice, and if we don't, we're at risk of legal action against us.
Absolutely.
Or being deregistered, which is awful. So we have to maintain our registration annually. We have to maintain our, the next one down, CPD. We also have to have insurance. Obviously we have to act with integrity, and we work within the code of ethics. these things are really important, and we will talk to students over the years about this, and we really will bring this home in fourth year.
Yeah, that's when you really need to know it.
Yeah, and they will hear about these things in practice when they're out in prac, because this is what the profession is watching for, this acting with integrity, the professional behaviour, monitoring your own self-management and all those sorts of things are critically important, because everybody who takes our students on prac is saying, would I want to employ this person in the future? Would I want them on my team?
Yes, yeah.
So that's what they're really asking.
And some of these things come and go as well. Like, we're all human. We can all have like a breakdown in our life where we just, at that point in time, we're just not safe to go to work. And either don't go to work that day, or you might take a little break from the profession, or so part of that is knowing what's best for the people that you work with. That's what all this stuff is about.
Yeah, thank you. I think we'll finish there.